Hello, and welcome to another session of updates from OU, Things to Know in Surgical Pathology. I'm Louis Hassel, and my guest today is Dr. Zoran Gatalica, who's our Director of Anatomic Pathology here at OU Medical Center, and he has prepared some interesting remarks on a topic that is very pertinent to our time, that of the NTRK fusion issue. So Zoran, I'll let you take it away from there.
Thank you very much, Louis. So here I am, I think for the first time on your podcast or YouTube, not first time on YouTube, but certainly first time from the OU. And let me try to share my screen. That might be a bit trickier. Here we go. That's the one. Let's share a screen. Let's do this one. Share. And this. I hope you are seeing what I'm seeing. And that would be a lecture. See if I can get rid of this on the side.
Yeah, use your slideshow option and just go from the first.
Come on, where's my slideshow option?
Up at the top menu bar.
Looking at it, slideshow.
Right there, yeah.
All right, from beginning, I guess.
There you go, yeah.
Here we are. So again, thank you for the introduction. I am very happy to be a member of the Oklahoma University Medical Center and the School of Medicine. And let's start with the neurotrophic receptor tyrosine kinases. These proteins are known as tropomyosin receptor kinases, while their genes are known as NTRKs 1, 2, and 3, and gene products as TRK A, B, and C. Confusing enough for everybody to try to remember that. But what it is that these are the receptor tyrosine kinases that are expressed in the predominantly neural tissue, where upon the binding of their ligands, they exert the physiologic activities on their targeted tissues. What can go wrong in cancer is, of course, everything. And that includes the aberrant expression of the ligands as well as the aberrant expressions of the receptors, which in that case become oncogenic drivers and then can lead to the malignant growth. We have, as I said, 3 genes, NTRK 1, 2, and 3, which are then in cancers usually rearranged to the point that they're on the 3' end. They are then binding to a 5' region of an unrelated gene that then drives expression of this protein. The thing is that in order for that protein product, fusion product, and NTRK receptor tyrosine kinase to be active, that fusion has to be in frame, meaning that there is no loss of the information or there is no shift or premature stop codon generated. Once that is happening, then the NTRK receptor tyrosine kinase becomes constitutively active without the ligand binding necessity. There has been many different types of, let me just move this way, of fusions that includes all 3 genes, with the different partners. And this shows a list of partners that have been so far identified in tumors where NTRK has been rearranged. There are 2 kind of distinct groups of adult cancers and pediatric cancers where you see NTRK fusions. And in pediatric cancers, listed here as a classic example would be infantile fibrosarcoma or a congenital mesoplastic nephroma, where you would find a very common fusion with the ETV6 in it, while on the other hand, in adult cancers, it's a bit less frequent to find these fusions, but the value of finding a fusion will become fairly soon obvious. What we are looking for is a fusion that can be targeted with specific therapies. And as said and shown on the previous slide, the presence of fusions involving NTRK is common in some very rare tumors. On the left-hand side, you will find that, as mentioned before, congenital mesoplastic nephroma, infantile fibrosarcoma, and secondary breast cancers are almost defined by presence of the NTRK fusion. However, these are rare cancers. On the right-hand side, you will see a lot of common cancers in adults where NTRK fusion is rather rare. Examples are listed here, and they can go from less than 1% to about 5% in different cancer types. We looked at the general population, so non-selected population of patients that have been sent for a comprehensive sequencing at 3 different institutions or consortiums, and found out that overall in a population of cancer patients, NTRK fusions are well below 1%, somewhere hover around 0.3% incidence. What we have here is a way to identify these fusions. There are certainly different methods that detect different parts of fusion. Protein part, the protein product is detected by immunohistochemistry. Gene rearrangement can be detected with fluorescent in situ hybridizations. The gene product, the RNA product, can be identified using RT-PCR, and that can also be detected as a part of a comprehensive analysis of cancers that is offered in next generation sequencing. So the first 3, IHC, FISH, and RT-PCR, require pretty much defined target to look for. In IHC, that is a protein, more correctly, the epitope, which is the tyrosine kinase epitope in the antibody that recognize. In FISH, you have to know which 2 genes are in the fusion, or alternatively, you can just look for 2 probes within the same chromosome and see if they break apart in case of rearrangement. In RT-PCR, you're looking at the RNA, which is fairly sensitive and specific, but again, has the same problem. You have to know which genes are included in fusion. Again, comprehensive methods such as next generation sequencing do not suffer from that problem. So an open-ended question as to what is involved rather than which one is involved can be answered. However, there are limitations there as well as to the design of the next gen, whether it works off the DNA-based or RNA-based sequencing. And for the fusion proteins and fusion genes, the RNA-based sequencing is preferred. In the oncologic arena and from the oncologist perspective, ESMO has brought up this algorithm. European Society of Medical Oncology is ESMO, and they would like us pathologists to answer the question whether their patient is a candidate for treatment with the NTRK inhibitors. Now, since that is a fairly direct question, we need to give a direct answer for that matter. And the direct answer can be done somewhat depending on what's available at your armamentarium, at your hands, and whether that is a next gen available or is it IHC available, and so on. So if the histologic tumor type looks like what you would expect to be carrying an NTRK fusion, then perhaps the best way is to go straight to the sequencing to allow for the direct answer whether this patient is a candidate for therapy or not. If that's not the case, then I think there's a bit of a disagreement which way is the best way to do it. If, of course, the next gen is available, that's rather straightforward. You can do that and then confirm protein expression in positive, fusion positive cases. Again, the reason for that might be in a way that the fusion is being done, whether there's a fusion product, fusion genes in frame or not, and then that will result of protein expression or not. So that's kind of a combination of the methods that we use. For the purpose of the FDA-approved therapy, it's important to do a confirmatory study that really shows gene rearrangement. For the common question is, as a screening method, certainly IHC is the preferred way due to its simplicity and widespread availability. For that matter, Ventana has provided a commercial assay that is able to detect TRK fusions and protein, as well as the wild type protein, because the antibody that is being used and the epitope is present in the conserved region of the molecule that is present in either normal wild type protein or in fused proteins. So that antibody is EPR 17341. As it said, it binds to C-terminal region of the TRK proteins, that's the conserved region, and the detection of it is facilitated with the chromogen as it is shown here as in brown. There are different, before going there are different subcellular localizations of the protein, and the normal one is certainly membranous, but in tumors, all bets are off, and the protein may be detected in the membrane, cytoplasmic membrane, in the cytoplasm, in the nucleus, or in all three. Important thing for pathologists and everybody else who's interpreting immunohistochemistry is, due to the fact that this is fairly a rare event in tumors, whether the negative result is truly negative. And for that matter, we need to have a tissue built-in control, and we have those. Those are the neural elements in almost every biopsy one can see, and they should, under normal circumstances and well-preserved tissues, be your internal positive control, as it is shown here with this biopsy of appendix, actually a section of appendix, where a neural elements in the wall, ganglia and nerves will be positive. When the tumors are looked at for the expression of the pan-NTRK or TRK C-terminal region of NTRK protein, then we frequently encounter a weak staining in tumors, like in this case, head and neck tumor, or in this particular tumor of a salivary gland. And those are suspicious, certainly, and in a proper setting should be further evaluated with the alternative method, as mentioned before, are the DNA or RNA method, and they, not surprisingly, frequently come back as negative. So the false positive result is possible, and as expected, it should be confirmed with the nuclear acid assays. In cases where there is a fusion, usually we see more intense staining and uniform staining of the tumor. In these two examples of a mammary analog of secretory carcinoma, we see a fairly strong nuclear expression. And in this case of a colorectal carcinoma, we see fairly strong cytoplasmic and membranous expression. So that in itself will give you an indication whether the fusion will be found or not. So in summary, we can just say that there are three different genes, and they are involved in fusion with many, many different partners. Having a fusion in itself, if it is not in frame, does not necessarily translate into a viable target. So that's one way to look at it, knowing how the fusion is being transcribed, as well as whether it is really present in the protein. Then finally, one has to remember that the drug approval is currently a companion diagnostic only based on the next generation sequencing confirmation of fusion. I'll be happy to take questions now.
Well, great, Zoran, this is a very interesting material and clearly sort of leading ahead in the paradigm of individualized care. Do you see the need for, say, a moderate volume surgical pathology laboratory at this stage to bring on this pan-NTRK antibody for routine use in adult and other tumors?
I think that's question that has several layers in it. Financial layer, number one, and then secondly, expertise layer in it too. So let's go from the back. most of the pathologists are certainly familiar with immunohistochemistry and can interpret that without much of a problem, positive, negative, and equivocal cases. So from that perspective, it's not that difficult to bring it in. The financial part of that is a significant question, of course. And then I would say moderate level of throughput in pathology lab might be a relative thing. If you have a cancer center next to you, and even though you're not a referral center with hundreds of thousands of cases, you have a very specific need for the presence or availability of this method or this stain, because NTRKs NTRK inhibitors are very successful drugs in treatment patients which are refractory to other therapies and carry that particular fusion in it. So I think that for practical purposes, us, you and me working at a cancer center, I think that would be, yes, resoundingly, yes, we should have it in-house. Yes.
So I'm really intrigued by the paradigm you mentioned there, where this is common in uncommon things and rare in common things. So can you think of anything else in pathology that's kind of like that, aside from accuracy of diagnosis, perhaps?
Yeah, I think we actually are seeing that more and more. You know, life was simpler when you and I were residents. Immunohistochemistry just started to come in here, and next gen was an unknown term. So things have changed a lot in the last 10 years, and they are changing dramatically with the increased use of the molecular genetic methods. And so, yes, we actually are seeing a whole lot of common things in rare cancers and rare in common things. But unless you look for it, you won't find it. And so that's something that I would definitely come up with many other weird examples. But to just simplify that, gene fusions are a whole new arena of potential for oncologic treatments. And they do not really follow the usual understanding that you can recognize it by the tumor type. You basically cannot. And so unless there's a need, I would say, unless there's a need for a therapy in a patient, that is a curiosity. But once a patient really is considered for the therapy with a rare but treatable genetic abnormality, then the answer to your question is there's a lot of examples like that.
Yeah. The other thing I think many people may wonder here is whether or not there's going to be a difference in therapeutic response based on whether it's you know, gene 1, 2, or 3 that's involved, and whether we're going to have to go down to that level of further refinement eventually to become more predictive or otherwise. And maybe it's too early to know that data. Do you have any insights on that?
Let me try to pull some of my data here. All right, let me share a screen again.
Yeah.
So sharing this screen here, we see clinical responses to TRK inhibitors in NTRK fusion positive cancers. It does not answer your question directly whether a specific gene fusions bring more or less in response. But as you can see that here, the overall responses to 2 drugs currently approved for the NTRK fusion positive cancers, larotrectinib and entrectinib, have a really good response rates. As you can see that the overall response rates are here, 75%, that's very high. And then with the entrectinib, which is a little bit less specific NTRK inhibitor, somewhat lower. So, and then there's, as you can see that here, a whole number of different tumor types that were treated in these trials, and response rates are pretty good. In some of these cases, although they had only 3 cases, all 3 responded really well. So I think that it is an intriguing question that will require certainly good diagnostic workup and then a good follow-up. And in the long run, it may end up saying that some are more susceptible than others. We have seen some really, I would say, strange genes involved in fusions. And sometimes that gene fusions do not translate into detectable protein with immunohistochemistry. So another layer to that question is, has the fusion been confirmed at the protein level as being relevant? Has it been before that confirmed at the RNA level that it's actually, they can be transcribed appropriately? So that's a something to be answered in years to come as we see more increased use of this type of inhibitor.
Well, thank you very much for this very insightful update. I'm sure that there's going to be a need for a further update here not too many months down the road as we learn more about this and get more experience with these drugs and various tumors, and potentially develop more robust algorithms that can be widely and more easily applied in a broad number of settings. So thanks, Zoran. It's been good to be with you, and we'll sign off at this point.
Thank you very much, and I go back to work.
Okay.